Okay. Good morning and good evening. I'm Dr. Pang Yun Cho, and today I and my colleagues, the Professor Ting-Chen Lu and the Professor Junior Tu, will co-moderate this webinar. And today we are so happy to invite the Professor Vasant Radhakrishnan from India to give us a lecture today. At the first, I would like to introduce our three panelists, and then later Professor Ting-Chen will introduce our visiting professor to give these lectures. So we have three panelists. The first one is coming from Texas, the UT Southwestern, Professor James Seawood, and he is the expert in the palatoplasty for the Cleft patient too, and he able to give us a lecture in ICC before. And our second panelist is our own Chang, the Professor Ting Lu, and she will co-moderate this webinar as well. The third one is Professor Handa from Iwate University from Japan. So, Ting-Chen, please introduce our professor today. Thank you.
Hi. So Dr. Vasant is a maxillofacial surgeon and a consultant at Charles Pinto Center for Cleft Lip and Palate, Jubilee Mission Hospital in India. He's specialized in cleft lip and palate and craniofacial anomalies. He is a specialized in cleft palate repair, and he has lots of experience of buccal myomucosal flap for the primary cleft palate repair and VPI surgery. So today it is our honor to invite Dr. Vasant to share his experience.
Yes, Dr. Vasant, please. Thank you.
Shall I share my screen?
Yes.
Yes. At the onset, happy Easter to everyone. It's a great honor to be in this August gathering. And I'm here to discuss with you my experiences with the buccal myomucosal flap in both primary and secondary cleft palate repair. I started out in this field of cleft lip and palate surgery in 2005. And for a great number of years, up to 15 years, it was we were using the mucoperiosteal flaps for cleft palate repair. The two common techniques were taught to us by Dr. H.S. Edenwala, my guru, and one was what he called the Pinto modification of Waddell's repair, and this is a modification of the two-flap palatoplasty. And the second one is the Waddell-Kilner V2Y pushback palatoplasty, which we used for incomplete clefts. At the point of time when we began, these two techniques gave me excellent results. Initial results had a fistula rate of less than 1.5%, and these techniques and initial results gave me the confidence to continue in the cleft specialty. So this basic short overview of what we used to do. This is the two long flap palatoplasty and the muscle retroposition, and the muscle is to be dissected free from both the oral and nasal layer and brought together in the midline posteriorly and closed. As we notice here in this picture, we can see that there is considerable raw area as the palatal mucoperiosteal flaps are moved medially. And this was one of the main issues with the technique. The raw area became a scar, and the scar solidified and consolidated and constricted the maxilla and had a lot of issues as the child grew. At the Charles Pinto Center for Cleft Lip and Palate, for the last 14 years, I've been working there. The advantage of working here is that there is a regular follow-up in a higher percentage of patients up to growth completion. And cleft lip repairs, which look good in the initial years, worsen as the time passes and the effect of maxillary hyperplasia took over. The last section of our patients had varying degrees of maxillary hyperplasia, many present at 5 years of age with a class 3 facial profile. The hyperplasia persists at the alveolar bone graft and into growth completion. Basic statistics from our department, which we collected, we start definitive orthodontics at 12 years of age. And what we found out that in VO3 and VO4 clefts, 60% of the patients treated for orthodontics were recommended for orthognathic surgery. An internal study of 400 patients with cleft operated between 2013 and 14. The speech assessment at 5 years for WO3 and WO4, we had 207 in WO3, out of which 98 had mild hypernasality, 4 had moderate and severe hypernasality in 2 patients, with normal resonance in 103. Out of the 104 patients with hypernasal resonance, 40 had misarticulations. In the bilateral clefts, WO4, we had no patients with normal speech. Mild hypernasality in 26 and moderate in 6. 18 patients had misarticulations. So we understand that the use of microperiosteal flaps were one of the main contributors to maxillary growth restriction, and it's well established. Avoiding the use of microperiosteal flaps or delaying the use have shown to have better outcomes. Brian Somberland's no flap palatoplasty was one of the techniques which were earlier in vogue. So in 2016, I first heard of Robert Mann. Dr. Edamwala in the OPD had a communication with him, and he had been just introduced. Dr. Edamwala had been just introduced to the ACRP technique. And when he told me that there's this man called Robert Mann, he's using 2 buccal flaps to close the palate. I just looked up and said, isn't that too much? And yeah, then we got him to our center in a workshop in 2017. And at the same time, he published his outcome results of 505 cases, where his results showed that it definitely make a difference if you follow his philosophy. And in 2002, just before I started the anatomic cleft restoration philosophy, he sent this video, how to decide what operation to do. An excellent video. If you can get hold of it, it will make the concepts in this philosophy very clear. So we knew that the furloughs technique was the core of the anatomic cleft restoration philosophy, because the soft palate operation was various modifications of the furlough. So Dr. Philip Chen, who had come down to our center in 2014, demonstrated the technique in 2014 to us. And so we decided to start, before going on to the anatomic cleft, we decided to start with the furloughs procedure. Everybody knows it's a very common procedure for use in the last 50 years now. So I'm not going into too much details. And there are a lot of papers now which establishes the furloughs procedure as a better procedure as far as speech is concerned. Now, as a beginner, when we start off with the furlough, the first question that arises is whether the flaps will come together. And because of that, we decided to be selective, case selection. And we start off with submucous cleft. And we never hesitated to put releasing incisions in case there is tension in closure, if you feel the cleft has widened or after the flap is decided. One also, since we have already seen Dr. Mann, we are confident about using buccal flaps in these cases. So with submucous cleft, the first thing we noticed, the nasal mucosal flap had a high risk of being buttonholed or too thin, rendering it unusable. Though the functional aspect of the cleft palate is the posteriorly based myomucosal flap, the role of the nasal mucosal flap cannot be undermined. The reason is, if the flap necrosis, the entire muscles will come forward back, and because of the scar that is produced in that area. So just an example of submucous clefts, how we proceeded. Submucous cleft, and it's a complete cleft palate. The dissection which we did had started, we started on the nasal side, so that we had an idea if the nasal side goes wrong, we could either complete it in our traditional fashion and go in and do a radical muscle dissection and close it off. So once the nasal dissection is done, one may proceed to close the nasal side, and the nasal flap is first sutured and then into the defect created by the nasal myomucosal flap. The incision extends to a level such that there should be an easy visualization of the eustachian tube opening once the incision is completed. So here the nasal mucosal flap is sutured to the defect of the nasal myomucosal flap. And then the nasal myomucosal flap is completed, sutured horizontally and retroposing it into a more anatomic position. And then the vertical limbs are sutured. Following which we take the oral flaps, and the oral myomucosal and mucosal flaps are closed, and we use an incision, lateral releasing incisions to close the hard palate. So this was the furlough. It came to a point where we had to use the buccal flaps, and that was when we started off. This was a very wide Wu2 cleft palate, and perhaps the most widest one I had done. So we were at a loss, and the child had been off and on in our department. We were at a loss to use the mucoperiosteal flap. So finally, this decision was taken to use the buccal flaps. And we, at that time, we took the widest possible buccal flaps that was possible according to us at that point of time. And this is what we also did do a mucoperiosteal release. And that is why I don't call this one a CRP surgery. So the mucoperiosteal, one side mucoperiosteal release to bring the palate, the flaps closer, and then a nasal side, opposite side nasal buccal flap went in to close the nasal side. So we got a closure. The child was already 4.5, 5 years old. We got a closure, and her speech improved, though there is still much to be done regarding her speech. She came back for flap division as she was having issues with the molars, which has already been, as you can see, the molars are already erupted. So she wanted the flap division, and we did the flap division, and she has gone home, and she's coming back for speech therapy regularly. So now anatomic cleft restoration philosophy is what Robert Mann calls it. He's combined double opposing Z-plasty with buccal flap in 8 different ways. The type and tissue deficiency in the cleft palate dictates the type of repair, and he called it anatomic cleft restoration philosophy. So what do we mean by that? So each surgery is customized to the patient, and since there are 8 different types, he used to customize the surgery to a patient. Now, the main objective is to restore the missing tissue. So he believed that there's a malformation and there's tissue missing, which needs to be restored. And the restoration is done by tissue replacement. And the tissue replacement, by doing it this way, we reduce scarring, we reduce the contractures, we reduce the maxillary hyperplasia. We also have to protect. What we have to protect? We have to protect those tissues which cannot be replaced, they being the muscles of the soft palate. So the levator and all the muscles of the soft palate, they have to be protected and maintained in the anatomic position. So Robert Mann had 8 different types initially, at least. We have used only 4, so I'm going to discuss only the 4 types. There is the type 1, type 2, type 4, and the no-touch bilateral buccal flap repair. Now, before we go into the palate, we just discuss an anterior palatal repair, which I believe should be done well if you have to successfully do without having fistulas. Now, this small flap, the mucosal flap, which is used in many palatal repairs and lip repairs, I have used it to line my anterior palatal and nasal floor repairs. And the lining effectively gives you a good closure up to around 1/3 the distance from the alveolus. So now we go into the SCRP type 4. In the type 4 is essentially a furlough on the nasal side, and also there is a furloughs flaps, myomucosal flaps and mucosal flaps on the oral side, but there is a fairly significant defect which is created, and this is filled in by the buccal flap. So here is the type 4 repair. It's a complete cleft, a Wu 3 cleft, and you can see the arrow pointing to the L-shaped mucosal flap, which is closed quite a bit, but not as much as I would have wished. Actually, most of our flaps would close a little bit, around 1/2 centimeter more into the palate. And here is the initial steps, the dissection. We elevate the mucoperiosteum, but we don't take a flap. We elevate the mucoperiosteum as much as we require, depending on the case. If it's a narrow cleft, the elevation is minimal. Otherwise, we can elevate up to the alveolar ridge. And then we close the anterior floor of the nose anterior palate with the vomerine mucosa and the nasal mucoperiosteum. The suturing is done in such a way that there is an eversion into the nasal side, and the sutures are all, knots are all placed on the nasal side. As we can see, this will give a chance for the individual repair to close by itself if you have good eversion onto the nasal side. So the next video is where we are doing the flaps. The first one is the oral myomucosal flap. As we can see, it's a bit different from the way we do our oral myomucosal flap in the normal furloughs, the technique. Here we extend around 1/3 the way into the hard palate, and a sliver of hard palate tissue is carried posteriorly. Then we have the dissection of the nasal mucosal flap, as we see in this, followed by the nasal myomucosal flap on the opposite side. So once these flaps are raised, the nasal myomucosal flap is raised, and it has to be free and sitting comfortably. Here we can see the final flap, that is the oral mucosal flap. And the oral mucosal flap is not completely raised in the type 4 in the way I do it. I don't bring it down to the maxillary alveolus. But this is enough according to me. Okay, so we have closed the nasal mucosal flap here, and the nasal myomucosal flap in the furloughs technique. And we close the posterior flaps in a 3-layered fashion. There are 2 stitches into the muscles, and the flaps are closed as we see here. The oral mucosal flap is short. It will extend a little bit into the closure. So we go to the buccal myomucosal flap. The anatomy is that buccal artery, a branch of the maxillary artery, enters the buccinator muscle at its posterior border. Anteriorly, the facial artery sends branches to the anterior half of the muscle and anastomose with the branches of the buccal artery. The superior 1/3 is perforated by the parotid duct. Now, according to me, it's a very important step. You have to positively identify the parotid opening before we start marking the flaps. The distance between the maxillary and mandibular gum pads essentially determines the width of the flap. But I would suggest that you would keep the width of the flap to almost 1.5 centimeters, even if we have to go a little bit onto the alveolar sides, on the mandibular side. This would essentially maintain the blood supply in case there is an anatomic variation in the blood supply. So this is the buccal mucosal flap as I do it. Here we have the outline. It's just skirting the parotid duct, and the tip of the flap comes very close to the commissure. So the closure is in the flap is designed in the as like the tip of a BP 15 number blade, so that when we close, we avoid getting a dog ear, which will sometimes can show outside. So it's very close to the commissure. So now we short video to show you how we take the myomucosal flaps, buccal flaps. So here it is quite close to the commissure, and right now we are over the modiolus. So a thin sliver of muscle is taken at this point, and this muscle is included in the flap till we reach the subcutaneous fat. And once we reach the subcutaneous fat, the dissection is continued just over the muscle, or leaving a sliver of muscle on the subcutaneous fat. I prefer to take the whole muscle and leaving no fat or any other material on the muscle. So the buccal fat pad is posterior, and it usually herniates if you don't control it. So we have to suture it to the underlying tissue, as we see here. So once we have raised the flap is turned inside into the oral cavity. Now, in the anterior part of the sutures are done first. So as you can see in this picture, the anterior part is done first. The second suture is placed at the base of the oral mucosal flap medially. And these 2 sutures will let you know the amount of tension in the flap. It's very vital, especially if you're closing a complete cleft, to have the maximum length and of the flap taken out, because every millimeter matters if you are going to close the anterior palate as is shown in the picture. So finally, the flap comes down and it closes completely, as you see in this picture. Now, this is another case of the ACRP type 4, and this is done in a Wu2 cleft. So you can see the buccal flap is coming and it is closing and sitting nicely after the closure. Now, the type 1, at one time, according to Robert Mann, it was the most popular technique to close. Right now, it has been reserved for palates which have hypoplastic tissue or tissue deficiency. So it involves a furlough, but in this furlough, the flaps E and D, these pictures are courtesy of Robert Mann. He has consented to let me use it for this webinar. E is our nasal mucosal flap and D is a buccal flap. Now, the nasal mucosal flap never reaches its intended destination. So that defect is closed by a buccal myomucosal flap. And also, if you have deficiency of tissue in closing the nasal layer, the buccal myomucosal flap can come into that place, as we see here. So let's go through that. And then it is just like the type 4. We can use the buccal orals, the opposite side buccal myomucosal flap to close the palate. So here is I'm sorry for this picture, but we have, as you see, an uneven, unequal length of the palatal soft palate shelves, and also there is kind of shortening of the soft palate shelf on one side. So this is the technique. This is what we have done. We have first raised the nasal mucosal flap, which is a short, stumpy flap, as we can see here. And then we do the nasal myomucosal flap, just like in the furlough, and it is nicely dissected to come and sit in its final position. The oral mucosal flap is done more extensively, as we have to use its posterior aspect to let the buccal myomucosal flap come in nasally. So this is a more extensive dissection, and it comes down right to the posterior aspect of the maxillary gum pad. Okay, and once this is done, we raise the oral side myomucosal flap. As you can see, the incision is started quite anteriorly in the hard palate. One must be careful not to go into the area of the greater palatine vessels when we do this, and we push the muscles posteriorly, and with this technique we can easily reach the opposite side to close the myomucosal flaps. So now this is how it looks like after closure. We have the mucosal flap not reaching its intended area, the oral mucosal flap, and the posterior myomucosal flaps, which are sutured. So the nasal defect is closed by buccal myomucosal flap, which has come into the palate. And then we close the oral mucosal flaps with the posterior myomucosal flaps and create a defect, which is closed with the opposite side buccal myomucosal flap. So the green line shows the oral mucosal flaps, which forms a wedge between the buccal flap and the posterior flaps. The blue line is the border of the nasal buccal flaps entering the soft palate. Now, very important with the function of the buccal myomucosal flap is that when we do a furlough, very often we have to pull the posterior flaps anterior to get a closure. The use of buccal myomucosal flaps almost avoids this process. The flaps sit very close to the posterior flaps, and it can be closed without any tension or pulling. Now, type 2 ACRP, it has become the mainstay of the buccal flap technique. The largest number of clefts, as far as Robert Mann says, that he uses this now as the modified version of this flap. We don't use it as much as he says he does, but we reserve this for most of the wide cleft palates with sufficient tissue. So this is the technique, and you can see how that this is a Wu2 cleft, a fairly wide Wu2 cleft, and you can see the markings. And we have closed the nasal mucosa, after which we have outlined the cuts, which are a transverse cut and creates a diamond-shaped defect in the center of the palate. Now, the buccal flap comes in to fill that defect, and as you can see, that's a complete closure of the buccal flap in that area. The nasal defect is completely filled. The posterior retropositioning of the muscles are very good. And now we have closed the oral mucosal flap over that buccal myomucosal flap, and you can see the defect, which is closed with buccal myomucosal flap from the opposite side. So this is the ACRP type 2. Now for the no-touch technique. We use the no-touch technique sparingly, but it has a specific use in submucous cleft palates, especially in our center. We have children coming in at 10, 12, and 14 and 15 for submucous cleft palate repair with poor speech. So at that time, we treat it like a secondary repair, and we do a bilateral buccal flap technique where we interposition it and push the palate back. However, it is not a fully no-touch technique. We open the submucous cleft and we close the midline after dissecting the muscle at the edges. This is an anatomic variation, an interesting variation where the cleft palate muscles are attached to the hard palate cleft margins. And the uvula was actually lying between the line connecting the maxillary molars. So this is a different variation. And what we did was, I would have been at a loss if I had to do it with a traditional technique. But here we separated the muscles from the edge of the cleft and pushed it posteriorly and did the nasal floor repair. And it created a fairly large defect, which was filled with a nasal buccal myomucosal flap, and it was closed on top of that with the opposite side, oral side closure with the buccal myomucosal flap. Now, we have to decide where we have to, which type of clefts go in for which type of ACRP. So for WO1, furlow Z-plasty is still the technique of choice. Small releasing incisions are still done posteriorly in our hands, and it may be used if any tension in oral side mucosal flap closure exists. Buccal flap might be added if there is more tension. So, but for essentially WO2, WO3, and 4, ACRP is the method of choice. Now, it's a personal assessment. I have made measuring over 70 cleft palates, and I've seen that at the hard palate, soft palate junction, if your width is less than 10 millimeters, and at the same time, the length of the soft palate, that is from the base of the uvula to the hard palate, soft palate junction, is around 40 millimeters or more, we can easily do an ACRP type 4, and that is essentially a furlow in the soft palate, and then close the hard palate with a buccal flap. So that is the ACRP type 4. ACRP type 1, there is a deficiency of, we usually do a type 1 procedure when there is deficiency of tissue, making the nasal air closure difficult, short soft palates, short and hypoplastic tissue in the soft palate, and wide bilateral clefts. So where there is tissue deficiency, we use type 1, in which there is a furlow and inadequate closure of the nasal flap. ACRP type 2 and most of the other clefts, wide cleft palate with adequate palatal length, mainstay in WO2, WO3, and narrow WO4 bilateral cleft palates. So no touch technique, short submucous and hypoplastic WO1 cleft palates, submucous cleft palate in children older than years with poor speech. Now, it's early days for us. Speech outcomes, individual assessments for group of patients operated in the first half of 2023 is promising, as per our speech pathologist. And there are some complications which we have to look into, first being the salivary accumulation, buccal fat pad herniation, and flap loss. So salivary retention presents as a swelling on the cheek from the second postoperative day, usually subsides by the 7th postoperative day. One child needed re-exploration. Posterior sutures were removed and the collection drained, usually caused to either a damage to the parotid duct or its opening, or the suture during incision, or the sutures passing around it while closing the donor side. Identifying the parotid duct opening and avoiding sutures in the area around it, surrounding it, will prevent the occurrence. Now, buccal fat pad herniation usually herniates through an open suture line posteriorly and usually regresses in about 6 months. So we don't really have to worry about it. However, if the fat herniates more anteriorly, it might interfere with the aesthetics and feeding, and the parents are very concerned. So there was one case where the fat herniated anteriorly, and we had to go back and excise the buccal fat. It usually firms up and becomes fairly firm in about 7 to 10 days. Now, flap loss and fistula, 2 cases with 50% or more of the buccal flap loss has been there in my list. The probable causes are the flaps where the complete flap length was not used and we had to stretch it to close the anterior, which is one thing which I don't do anymore. In any complete clefts, now the complete length of the flap is used, and the flap is also never narrowed down. So we don't narrow down the flaps to fit the width of the cleft. So if it is a narrow cleft also, we take usually 1.5 to 1.7. Now the fistulae are, they're fairly easy to close. That's one thing good about the technique. I know we have to still violate our principle and go back and take a mucoperiosteal flap, but then it's easy to close. And with minimum mucoperiosteal flap, we can move it medially, usually from one side, and close the fistulae. Now, there was a jump in fistula rate from 1.5% to 3% for us. And most of these were in the early days and significantly reduced in 2024 and 25. Fistulae at the mid-palatal regions, usually at the junction between the oral mucosal flap and the buccal flap. That's where the maximum stretch on the flap is healed spontaneously in 6 months to 1 year if the buccal flap is intact. Anterior fistulae are more common, and VO4 clefts in VO3 and VO4 clefts where the anterior repair was inadequately done during the lip repair. Most of the smaller fistulae were closed by advancing the buccal flap into the defect in 2 layers. So fistula closure was done usually if there was a persistent complaint of regurgitation of food through the nose, usually 1 year after primary repair. And in our culture, the food is very spicy. So the children find it very difficult, even if there is a small opening. So we have to go and close the fistulas. Those who don't complain may be closed at the time of flap division. Now, buccal myomucosal flaps, the secondary cleft palate surgery, we do use it for, and it's very common as far as I've heard, that it is now being used for the correction of VPD and also for fistula closures. So in children under 12 years, buccal myomucosal flaps have become the primary modality of VPD correction. So in our center, VPD assessment is by a perceptual speech assessment by the speech pathologist and nasoendoscopy. So the 3 procedures were used in our center in the last 10 years. The first is the Furlow's Z-plasty redo palate procedure, the superiorly based pharyngeal flaps as described by Philip Chen, and the buccal myomucosal flaps, the no-touch technique. So in nasoendoscopy, small gaps with bubbling having a closure of more than 80% of the port at rest is usually treated with a redo Furlow's palate. Usually, if there is bubbling and a small port opening, we do a redo Furlow's Z-plasty. All the rest of the patients are treated with the no-touch buccal myomucosal flap technique. Pharyngoplasties are now reserved for all those patients who have developed VPD post-orthognathic surgery and for those patients who have an immobile palates in nasoendoscopy. So no-touch technique. There is a transverse incision in the soft palate, completely releases the scar, which is present in the middle of the soft palate, immediately posterior to the hard and soft palate junction. So this is the area. We leave a small cuff of tissue in the hard and soft palate junction to take our sutures. The incision curves medial to the pterygomandibular raphe. And we have to identify the entry point of the palatal muscles, probably mostly the levator, as we end the incision. Now, one thing which we see always is that there is a relapsed muscle retroposition. Whenever we have done, in which all cases we have done radical muscle dissection and retropose. In fact, that was being done for the last 20 years, from 2002 to 2020 in our department. And we have seen most of those muscles coming back and reattaching to the scar in the middle. As I see, those yellow lines are the muscles getting attached to the hard palate. So there is a release, and once the release is done, the soft palate falls back automatically into its natural position. And the significant gap which is created is filled with a nasal myomucosal flap, buccal myomucosal flap on the nasal side. And the oral myomucosal flap from the opposite side comes and closes over it. Now, one must understand that you don't have to pull your buccal flap on the oral side all over the opposite side nasal flap. It's enough if you cross around 1 to 1.5 centimeters beyond the midline. And when the scar heals, this will pull, the contracture of the flap will pull the buccal flap from the opposite side towards the lateral. So another important thing which we have noticed from my first case in the bilateral buccal flap VPD correction is that there is a chance that the patient might chew immediately after post-extubation. It might be a very snapping bite which may damage the base of the oral side buccal flap. So after that, we have been using a bite block which has been consistently used for all our patients now when we go in for this same procedure. And it can be removed and cleaned by the patient, and they are very comfortable using it. So we use it for around 7 days, after which it is optionally used only during the night. Now, flap division is optional in these patients, but most patients opt for it. That's because there is a lot of cheek bite happening, especially when the second and the third molars are erupted. Usually done under local anesthesia in older children, and the flap settles and integrates well, as you see in the last picture, after the division. Now, we have seen 70% of the patients below 10 years of age demonstrate velopharyngeal closure during speech. The closure is dependent on the pre-existing insufficiency, but usually adequate. The recovery is less in patients with large gaps with minimum movement of velum postoperatively. Further corrective procedure with the pharyngeal flap may be required for these patients. Robert Mann suggests a palatal suspension with the pharyngeal flap. We have not done that procedure till now. And we usually go back to pharyngoplasties if it doesn't succeed with the buccal flap procedure. So this is the outcome. The first one is the preoperative endoscopy of a patient. You can see the hypernasality in the nasal air mentioned. And this is the postoperative. You can see that the palate has moved quite posterior. Now, fistula closures, buccal flaps can be used to close fistulae in the in the posterior two-thirds of the hard palate. It's not easy to reach the anterior of the hard palate. I would still prefer to use tongue flaps because the working end of the buccal flap may fail in a fistula closure. That's very vital to have the working end vital. Unlike the primary cases, in the secondary cases, the nasal side and the surrounding recipient area may not be very healthy in a fistula. So this is a palatal breakdown, an example, a case which a patient which came up to us around 2 weeks ago. So we can see that this has been operated twice with the traditional techniques. Both the times, I don't know, the palate had broken down and the whole hard palate was scarred. I probably think that the greater palatine vessels would have been damaged, and we have to replace tissue if we have to repair this. So this is how it looked at the time of the beginning of procedure. And the nasal layer is closed and the muscles are released from the nasal side. Now the palate is released completely. The soft palate muscles, which is scarred and shrunken, is released into a posterior position and closed in 3 layers. The soft palate is repaired in 3 layers. Excuse me. It's repaired in 3 layers. And then we bring in the nasal side buccal myomucosal flap into the defect. But here there is a little deficiency of tissue. We are not able to get a closure in this area with a flap because the area was very deficient of tissue. So we don't have an oral side flap to close. We have to stretch the buccal flap and close it onto the nasal flap, nasal side buccal flap. And it has held on, and we have this at the 7th postoperative day. So that is the end of my presentation. Dr. Edenwala had told after seeing Bob Mann's workshop in 2017 that this is not a procedure for me, but I'm quite sure that this is the procedure of the future. Thank you.
Thank you, Professor Vasant, for that presentation and for your in-depth explanation of your techniques. So at this time, I'd like to welcome our panels. And the first one that I'd like to invite is Professor Honda.
Oh, can you hear me?
Yes, we can.
Okay. Sorry for late. Yes. I have one question for you.
Yes.
Yes. For the primary case, you use the buccal myomucosal flap for the 2 layers. Do you detach the flaps for even the primary case, right?
Do you detach in the sense, do you detach the hard palates flaps, you mean?
Yeah, the oral side or the nasal side even.
Yeah, so the mucoperiosteum is just elevated. We don't put a lateral releasing incision. So mucoperiosteum is just lifted off from the bone. And in my case, I do it as in how much I require it. But Bob Mann has said that you're free to do the entire area. You can lift it off and you maintain, as long as the lateral area is not disconnected as a flap, the blood supply is well maintained. And I think no harm is done as per.
Sorry, I mean the buccal myomucosal flap. Do you detach a buccal myomucosal flap? Detach at the primary case?
Yeah, you mean divide the buccal myomucosal flap? Yeah.
Yes, yeah.
The division is usually not in children immediately. It is done at the time of the eruption of the primary molar. Now, sometimes if the flap is lying over the alveolus, the molar comes right under it. So it's supposed to be done at the time of the primary molar eruption. Very often, the flap is pushed posterior by the growing maxillary and mandibular alveolus. So in those cases, you can avoid the division, and you can divide the flap whenever you take up the patient for alveolar bone graft or any other secondary surgery. The thing is, it's better not to divide early. So I have personally not done it because we have not reached the stage where we evaluate our patients for VPD, but you can still use the anterior flaps and use the flaps if you have it attached to its blood supply and turn it around into a fashion where we can use for VPD correction at a later date. So you can lift the flaps from the hard palate and then move it on to in a transverse fashion. If you have not divided the buccal flap. So it's usually around 6 or 7 years of age, we can make a decision on that. Yeah.
Okay, thank you very much.
Thank you, Professor Honda. Next, I'd like to invite Professor Tinchen Lu.
Hi.
Hi.
It's good to meet you here.
Yeah.
Yeah, I have very few experience of the buccal flap. Question about can you use the flap again? Like if you already harvest both sides of the buccal myomucosal flap and you want to use it again?
Yeah. So the thing is, I've not heard of it being harvested again from the buccal side. But as I said in my reply to Dr. Honda, is that we can use the flaps which are used in the primary palate repair itself. And we have to lift the palate off, flap off from the oral side. If it is a bilateral flap, we have only one flap to be used. That is the oral side buccal myomucosal flap can be lifted off if its blood supply is maintained, and it can be used in a transverse fashion. It can also be tunneled into the nasal side. A friend of mine has done it. He has tunneled it into the nasal side to give a double layer of buccal flaps in the nasal side. So yeah, if you have not divided it, you can use it in the second time. But I don't know whether we can take another flap from the buccal, from the cheek. I guess it might result in mouth opening issues and all those problems. I'm not sure. I've not done it anyway.
Okay. So, okay. Thank you very much.
Thank you.
Thank you, Professor Lu. Next, I'd like to invite Professor Seward.
Well, I'd like to say thank you for an excellent talk. I think you explained that really well, and I really like your philosophies of kind of when you use it and when you use which type. I have some experience of primary and secondary buccal flaps, and I've kind of developed a bit of a love-hate relationship with them. I love them because they allow you to close these really wide clefts with fantastic, supple, soft tissue that moves well. And I think you do get really good speech outcomes with these very wide clefts. The hate side comes because I have had some flap failures, and they really hurt when you see kind of the distal half of the flap die away on both sides, and you end up with this massive hole that's a massive problem for these kids. In addition, I do find that at some point you're committing to another surgery for flap division, and so that again is kind of feeds into kind of the decision of when to use them. A couple of points that you made that I'd like to just emphasize for the group is that I really like the fact that you're using an additional piece of tissue to close up by the alveolus at the time of the lip repair. I think, these buccal flaps can be really hard to get all the way anterior to the alveolus. And I think that was kind of a nice enlightened way of kind of solving that problem. So you're not having to bring it to quite as anterior as the alveolus. I think that's an important point. So yeah, I thought that was really great.
Thank you. So regarding the problem of flap loss, as I mentioned in the talk, that we have had 2 flap losses, and both those losses I think were because we have underestimated the length and also the width. As I said, that we should try to maintain the width in almost all cases, and don't try to fit the flap to the defect, unless of course it's a wide defect. But do not try to bring the flap size, the width, reduce it to the defect. You maintain that 1.5 centimeters. And personally, I try not to go through the muscle. It's a personal choice, and I don't want to take a risk not to go through the muscle too often. I stay on the surface of the muscle and go right to the posterior. Now the tension comes when we have to pull it forward, and we have to reduce the width of the posterior part. That is somewhere we have to learn to juggle it and manage to get the things together. That the pterygomandibular raphe area and the area between the maxillary gum pads and the mandibular gum pads, in some cases, especially bilateral clefts, are quite narrow. So essentially your flap becomes very narrow unless you extend your flap width onto the gum pad on one side. And that means that you cannot turn it as much. If you extend it onto the mandibular gum pad a little bit towards the base of the mandibular gum, you may not be able to turn it. If you cannot turn it, you cannot reach the anterior. So these are the problems which I think you face. But I think it's better to maintain the width and not lose the flap at all. That is very important. Yeah.
Right. I guess the question I do have for you is, you gave us a really nice picture of kind of your anterior kind of flap design. And how important it is to really come up to almost to the lip and almost to the commissure. But when do you stop dissecting posteriorly? And how far down towards the raphe do you go? And do you ever cross the raphe if you need a little bit more?
Posteriorly, no. It is the gum pads, the posterior gum pads, and the area connecting the maxillary and the mandibular gum pads it is stopped there. I don't cross the raphe. The raphe, I was taught that the raphe is a continuation of the buccinator. So if you violate it, possibly you might violate the blood vessels entering. So there have been technique described where you tunnel under the raphe, but I have not tried it. I don't think it is required because this doesn't create any problems till now. I have not seen any cysts growing because cyst coming off inclusion cyst or any of those problems because the mucosa is lying inside raw tissue. There have been no problems till now, at least.
Thank you.
Thank you.
Thank you, Professor Seward. Last but not least, I'd like to invite Professor Low for some comments.
Yeah, Dr. Vasant, thank you for your speech.
Thank you.
I really enjoy your talk for using the buccal myomucosal flap. Then I think you know, I also noticed that from the literature, from the meeting, that I noticed that the buccal myomucosal flap is getting more and more reported and maybe more and more used in the palate repair, either primary or secondary. So I think that why in the past 40 years I had not used buccal myomucosal flap in my practice. Really interesting. I remember there's only one chance that I visited the Philippines. I saw a case with very wide oral nasal fistula that could not be closed with the local tissue. So I asked Dr. Bernie to use buccal myomucosal flap to help to cover the opening. And otherwise, I had no experience of the buccal myomucosal flap. But I think that this really is a nice and vascularized flap for covering the raw surface or the opening oral nasal fistula, or when you do the soft palate pushback, you can cover the anterior soft palate area. So I think the listener could learn from this technique, and in their practice, I think it should be a quite helpful flap to be considered in the practice. Thank you for your presentation.
Thank you.
Thank you, Professor Low. And now at this time, I guess we will then proceed on to our Q&A session. So we have a couple of questions first from Professor Fayyad. And the first question is, do you close the nasal layer in all white cases, or do you use buccinator as a single layer cover?
No, all the times we have to close the nasal layer. I don't think any flap is going to be healthy enough if you don't have an underlying nasal layer. So nasal layer closure is important. If you don't get the nasal layer closure, as we come posteriorly, I think we have to use a second side buccal flap, the nasal side buccal flap, and we can move it into the hard palate cleft also, at least the posterior part.
Okay, and the second question from Professor Fayyad is that how many of the patients where you use buccinator in primary palate closures get VPIs, and then what is your protocol to treat those?
Yeah, I think it is still very early for us. It's been around 2 years and around 250 cases. We started in 2022, which was only 3 cases, and from 2023 to now, it's just 2.5 years. So the babies are coming in at 3 years, the first assessment. We still don't have a number, but definitely what our speech pathologists have told, the speech is definitely better than a lot of what we had before. That's what the first impressions are.
Okay, thank you. And our next question is from Dr. Piercy, and the question is, are you raising the buccal flaps in the subfacial or subcutaneous level?
It's not yeah, it is the buccal flap is a complete myomucosal flap. So there is mucosa, there is muscle, and the dissection is between the subcutaneous fat and the muscle. Now, if you're confident of your dissection, you can keep a small sliver of muscle on the subcutaneous fat from inside the mouth, that means you will be dissecting through the buccinator muscle. That means that the problem with that is that inadvertently you can go deeper into the muscle, thereby violating the blood supply. So I am not confident. So I keep myself to just under the muscle, and I go in strictly in the fascial plane between the muscle and the subcutaneous fat.
Okay, thank you. And our next question is from Dr. Aslam. And the question is, can you please elaborate on the management of Stenson duct injury and salivary collection?
Yeah, that's a very important thing. We have had, I think, one case where we had to go back and open up we don't have to recannulate the duct or any of those things. Just leave the wound open, and usually the duct, the saliva finds a way to escape through the open wound. Now, we have used steroids when the swelling comes up on the affected site, and it does help, but I really don't know how it helps. We use dexamethasone 2 milligrams given 2 times daily whenever we see the swelling, but whether there is any relation directly to the salivary collection, I'm not able to say, but it does help in the overall management of the swelling. So there's been only one case, and we just let it open, and the problem was solved. So I have not faced anything else other than that.
Okay, thank you. And our next question is, what do you think of AI role in revolution to surgery and flaps?
Yeah, that's very difficult because I personally have not used much AI in surgery. But AI is a field which I feel personally at this point of time, we are at the stage, if you look at human or life evolution, we are still in the amoeba stage. I think we'll have to wait a few years to know what happens if it becomes a dinosaur or something like that. So it's too early to say anything.
Yeah. Okay, our last question is from Dr. Pranav, and then the question is, can you tell how often the buccal fat pad get exposed during the buccal flap harvest, and how do you avoid it?
Yeah, the buccal flap pad gets exposed, at least in our hands, almost every time. Unless you are going in a plane, as I mentioned, that you keep a very thin sliver of muscle on the fat, it doesn't get exposed. But invariably, most cases, the buccal fat pad is exposed. And the only way to manage the buccal fat pad, and there are, I feel, 2 or 3 different varieties. Some of them is so much like a liquid wax, it just flows out. As long as you can take sutures through the fat, you can tie the fat down to the underlying subcutaneous fat or the margins of your incision. So if you tie it down, I don't think it will herniate further. The number of fat herniations have decreased since we have been meticulously suturing the fat back into its position. So yeah, so that is the thing. There is no issue if it herniates also. Usually it subsides by itself.
And that's it for our Q&A session. Dr. PY, would you like to take over?
Yes, thank you, Junior. And thank you, Professor Vasant, to give us so comprehensive to introduce the myomucosal flap to repair the primary and the secondary the palate defect. Just as we know, since the 2017, the Professor Robert Mann in Michigan just published the article to address how he could use such kind of myomucosal the flap to restore the buccal and the palate defect. Just like the Professor Low and Professor Lu mentioned, in Chang, it's not so common to use such kind of flap to do the primary palate. So we still have to learn from all the experts in the world to know what is the limited and how it could be applied for such kind of different categories. Just like Professor Vasant today, you give us such much more different scenario to apply. One side shorter, one side longer, and the type 1, type 2. So we really learn a lot from you. Really, happy to have you today to
Thank you.
instruct all our audience in ICC. So before I have to conclude the webinar today, I will invite all our participants and we can open your screen to show you a smile. It's our routine and to have a group photo to celebrate the happy Easter, please. Coming. Oh, my friend, please show your smile with me. Hello. Yeah, good morning and good evening. Thank you for coming, Professor Fayaz. Hi, Fukui, Berna, Professor Handa, James from Dallas, Children's Dewey. Yes, and I will count to 3. Please give me a big smile, please. Okay, so now 1, 2, 3, cheese. Thank you so much for your coming, joining. And I have to advise that our next ICC presentation is the 7 days later, 1 week later. The speaker we invite is the Professor Hikosaka. So Professor Hikosaka is this year the Kyoto Cleft, the program, the committee chairman, and his topic, he will focus on the cleft Q and how the cleft Q in the patient of the clefts. So that will be very fantastic, and we will invite the relevant panelists to come join with for his talk. So once again, thank you, Professor Vasant, and thank you, James. Thank you for your day, and thank you, Professor Handa. Thank you, Tin Chen, and so thank you, all my friends, and here with us. Have a good day. Bye. Happy Easters.
Happy Easter.
Bye. Happy.
Thank
Thank you,
you.
Professor Basan.
You.
Very nice presentation. Thank you
Again.
very much.
Thank you.
Thank you,
Bye-bye.
James. Yeah.
Thank you.
Okay.
Dr. Chow, is this available
Yes.
on YouTube? How is it? How long will it be available if somebody wants to see this?
Say the video might
Yeah.
be tomorrow or 2 days later.
Okay. Yeah.
Yeah.
Thank you.
And I will give you the YouTube and I will record it and a little bit modify, edit it. Okay.
Yeah. Thank you.
Thank you very much. Yeah. Professor Fayaz, have a good day.
Yeah, thank you.
Thank you very much for your questions. Hi, thank you, Dean. Perfect. Okay. Bye. Thank
Bye.
you.
Bye.
Bye.